All right, can you guys all see that?
Yep, that's perfect. Thank you.
Well, as I begin today, I really would welcome interruptions today as we talk about this. I think the concept of sort of an initial psychiatric intake was kind of a difficult term for me to sort of put together, I guess, because I sort of believe that sort of diagnostic and therapeutic process kind of go together and incorporate this longitudinal sort of experience. So I tried to focus on things that I try to understand or look for at my first encounter with a new patient to me. But sometimes this process, I guess, gets kind of stretched out maybe over many visits, especially in my work with kids, because sometimes I don't have all the information, or highlighting that outside information from therapists or schools or different caregivers might add to the process. So I add a big caveat to this idea of a one-time visit. The other part I would also welcome, especially Amanda and Colleen, if you're on here, I think that sometimes perhaps maybe the medical piece of the questions I ask might be a little different than if you're focusing more specifically on therapies and sort of relational things. And so mine's a little sort of focused a little bit more on the medical piece, but I would add, and maybe more so, that that continued knowledge about learning about family relationships and interactions and the therapeutic piece of it is probably more important, and again kind of evolves over time. But we do have this thing, and I think it's sort of maybe a construct of maybe insurance of coming to see a psychiatrist or having an intake, which is really in my mind kind of just the first kind of start of building a knowledge base. We are kind of asked to write it for purposes of documentation and kind of organizing it into these categories, which I'm going to kind of go through. You know, the first part of it is really understanding this chief complaint, the main reason that the patient is there, as a place to kind of start with your work and understanding. And sometimes people come with lots of complaints or various complaints. Some of them are separate, some of them are the same. But I really want to try to understand it from that patient's perspective. The other challenge with this, whether you're working with geriatric patients or children, is that sometimes the chief complaints of the child or the parent are not the same, or sometimes the complaint of the school is not the same as the complaint of the parent or the child. And sometimes this concept of chief complaint also requires understanding the complaint from multiple viewpoints. Some common things that people present to or present with more than one complaint are things like suicidal thoughts, or mood problems, or problems with depression or anxiety, or behavioral issues, or memory problems. There can be a whole host of different things. And I try to use the concept of this chief complaint, what they really want to see get better, as sort of, I sort of equate this to my detective skills. I'm going to go through my evaluation trying to be a detective and try to understand this complaint better in terms of how to approach it. So these are some of the things that kind of matter to me. I want to understand that symptom, that complaint in its entirety. I want to paint a 360 degrees picture of how long it's been going on, the things that really contribute or worsen the symptom, things that they've tried already that may have worked or not worked to make it better, or continue to be challenging. I want to understand what are the other stressors that this symptom has caused. And I think function really matters. Sometimes, you know, if you're tired or you're having trouble sleeping, that's a complaint. But to really understand what the sleep issue causes, like, I can't sleep, I'm falling asleep at work, or I'm sleeping through the day at school, is a very different type of need than someone that just feels tired but is still able to do their work. So I really want to understand the impact that has on the functioning. this is just, again, a way of sort of writing it, but sort of thinking about, is this a patient with a known past history or sought treatment before? Or is this somebody that is presenting without a previous diagnosis? The other part that I think is really important is this concept of the pertinent negatives and what is not going on. And sometimes I think that this part of the discussion with folks is trying to exclude other causes, is a really important term, you know, and so not only do you have to sort of validate a diagnosis or get criteria to meet a diagnosis, but it's really important that you exclude other things. So often in psychiatry, there are so many things that can cause a common complaint that you have to not only rule something in, but you have to really rule things out. And so one of the things we're going to spend some time doing today is kind of how I kind of groups mental health issues into different categories and kind of how to explore those categories with some questions. Anybody have any questions about that part before we kind of get into, I'm sorry, I'm having a little trouble advancing. Before we kind of talk about kind of the nuts and bolts of some of the questions. Okay. The other really important part of these, we're going to go into these different sort of psychiatric symptom clusters to kind of talk about, is really the importance of understanding these vague symptoms, because lots of times people present and this is what they're complaining about. The problem is these things don't meet a medical or psychiatric diagnosis and can transcend multiple categories. So something like irritability or anger problems could present as anything from ADHD and sleep difficulties and sleep apnea to a thyroid problem to depression. And the scope is really broad. And so you really have to kind of dive in and go through these categories. And then when people are talking about behaviors, and certainly in work with kids, lots of times the chief complaint is a behavioral element that they don't like. Maybe there's back talking, maybe there's struggles to change their eating habits, or whatever the behavior may be. When you have a behavior, you have to go through and again understand that behavior, because behaviors themselves do not lend to a diagnosis either. It's understanding what is driving the behavior. And so I think some of you have definitely seen this slide before, this ABC model of behaviors that we talk about, you know, really understanding what the antecedents of that behavior are, what is happening before that behavior, what are the triggers, what are the patterns that lead up to it. The behavior, the how, what, why, and how often do matter, but it also matters what happens after the behavior. For an example, if a behavior is aggression and the complaint is someone's hitting someone or losing their temper, there's no diagnosis about temper tantrums or aggression that you need, but you have to try to decide, you know, is there depression driving this? Is there anxiety driving this? Are there impulse control problems driving this? And then also some behaviors have purpose. And if you don't understand the purpose or the outcome of the behavior, the consequence, it's also very hard to sort of decode its meaning. I've given this example a lot, but you know, if you have a child and you take them to the grocery store and they want a candy bar at the checkout line, and they start throwing a tantrum right there in the checkout counter, and you give them the candy bar, and the tantrum stops, you just created a very purposeful behavior. You just taught your child how to get a great candy bar. And so the consequence, giving that candy bar, may have been as problematic as the behavior. And really to understand that, if you're going to change the behavior, is really kind of reshaping the antecedents and the consequences that lends to a whole different sort of pattern tracking. And so the same thing sort of applies in just the diagnosis piece in general when behaviors are a large part of the complaint. Okay, so these are the large categories that we sort of refer to as psychiatric review of systems. And despite whatever the presenting complaint is, once I really understand or feel like I have an idea of all the associated factors and symptoms and the timeline of the chief complaint, I really want to start ruling other things out or seeing if there are other things that are overlying that might be contributing to these. And these are the 6 kind of huge categories of psychiatric illness. And it can include a lot of different things, but I try to make sure I screen people in all these categories to make sure I'm not missing things. So certainly many of you are familiar with depression screens, but depression can cause all sorts of mood and behavior problems and is often, especially in children, a real big cause of behavioral issues that go unchecked or school difficulties that go unchecked. And in adults, depression is one of the #1 contributors of morbidity and hardship at work and school as well. So it's really important to screen everyone for that. Specifically, you ask people if they've ever felt depressed or they feel like their mood has been down, but many people don't use that term. And so some people would just say irritable or moody instead of depressed. And the other thing that's a really clear one, some people would definitely report anhedonia or a loss of interest in things they normally do. And this sometimes is just as subtle as people saying, I'm bored, I don't enjoy anything. And that's technically, especially in younger people, what depression is. But the other thing people don't realize is sometimes along with the depression is those neurovegetative symptoms, that things like losing your appetite or eating too much, or changes in your energy level or your concentration and focus, all linked directly to depression as well. So kind of, I think everybody gets a screen about sleep and appetite and weight changes, because those can really be huge mood symptoms that can be missed. And certainly suicidality is very prominent in depression and also bipolar disorder, which we'll talk about here in a minute. Anxiety is an incredibly broad category, and we've talked about anxiety before, but screening people again with a lot of physical complaints or medical overlays when people present with tummy aches or headaches or fatigue, anxiety can be a big driver of that. And I talk about anxiety in the 3 phases. Sometimes anxiety is worry, brain worry, cognitive anxiety. Sometimes it's body stress and all the physical manifestations. And sometimes it's things like people that say they black out or they can't remember. They've kind of dissociated or not encoded things because of stress. And so trying to screen for all those things. Asking about concentration. I screen people for panic attacks. Have they ever had an onset of panic? Because a true panic attack is a very medically, biologically driven release that can occur that has sort of different treatment options. And then certainly I think that understanding the functionality of the anxiety is always important. Well, if you're anxious, what does it keep you from doing? Are you struggling to leave your house? Are you struggling to make decisions? Are you not able to complete things? And everyone needs a screen for trauma. And you don't have to know at the first visit what the trauma was or the details of the trauma, but you have to know that it was there, and you have to have some sense of how it impacted the person, because I think many of you in mental health know this, but I think it is always shocking to me and staggering to me, and as our students come in and round with us, it's always shocking to them how high trauma rates really are in our society, and probably still very underreported. In psychiatric populations, it's hard to find sometimes someone that doesn't have a trauma. It's so common in the population we seek. And everyone experiences that differently. I think if you look at kind of larger statistics, you have somewhere between a third and a quarter of all people reporting a significant enough trauma and PTSD symptoms at some point in time that this is huge. So we always ask about that as well. Psychosis is probably something I actually probably do a lot more than other folks in mental health, because it really does have a large contributor to needing medications. And it can be very challenging to ask about psychosis. one of the things I always tell people is not only do you ask, but you have to observe, because sometimes psychotic behavior is observable behavior that the person can't comment on because they may not be able to distinguish if it's real or not. And so you sometimes need additional collateral from family members as well. You can certainly ask people directly in a neutral way. Have you ever seen things or heard things that other people can't see or hear? I ask people sometimes if they felt they've had beliefs that really other people have had a hard time believing, and try to understand how they've dealt with that. I ask people sometimes if they've really felt like their life was in danger, someone was following them, to get at questions of paranoia. But sometimes it's also being very mindful as you're talking about something for listening to the paranoia. Or sometimes people are responding to things going on in their heads and trying to pick up on that as you talk to them. I think psychosis and this next section, mania, are often very challenging topics for lay public to understand. People misuse the term psychosis and misuse the terms mania an awful lot. So sometimes I have to describe what it is to people if they don't seem to understand the question, because they may misassign it to other things. And substance use can be a reason. I'll have, it's funny, I'll see a lot of people sometimes with psychotic or manic behavior, and actually their drug tests have come back negative, and I'm trying to get history from them. And the best the family can do, and I think it speaks to the issue of substance use in our culture, but the best the family can describe it, or the public can describe it, is that they just are out of their minds, they're high on something. Well, yes, it can look just like being high on a substance, but they're not, and this may be another form of illness. So asking for manic questions is really important. Every patient that has depression also needs screened for mania, but again, a very misused term. Lots of people think that it's just mood swings or racing thoughts, and again, I would put mood swings and racing thoughts in those vague symptom categories that overlap a lot of different things. So I really try to get specific details that I can. The two most sensitive questions to ask someone to really get at mania, if you're only going to ask two things, asking about a true decreased need for sleep, meaning you got by on several hours of sleep for a significant amount of time, usually 4 to 7 days, without missing it. It's not a feeling of being tired. It's a feeling of not needing the sleep, and that's a very important thing. That's waking up after 4 hours and feeling completely and utterly refreshed and ready to go. There are very few things in the world that cause manic decreased need for sleep. Substance use can certainly sustain a decreased need for sleep, but it's very unlikely that substance use can be prolonged with the short-acting nature of our substances without continuing to use. It's very difficult without continuous use of substances, even things like stimulants and cocaine, to maintain a decreased need for sleep. What you'll see in people that are using substances, at some point they will crash when the access does not occur. Folks with mania will not just crash. They will continue without the need for sleep, or very little sleep, until a medical intervention, usually medication, helps bring that down. In fact, the decreased need for sleep and not sleeping is a medical emergency. You cannot survive if you aren't sleeping. The other portion of that manic behavior that's very specific is the cycling energy. So this idea of not sleeping, but also seeing alternations in their energy level, true racing behavior. And this isn't just the subjective feeling of things going fast, but the whole body and the mind are moving fast. And these are usually observable to other people, like they're talking fast, they're moving fast. And again, it's sustained. It's not going to be something that lasts just a couple hours and then goes away. And then you can certainly ask about some of these other symptoms that we talk about, like goal-directed behaviors, excessive cleaning, excessive spending, irritability, flying off the handle. But they typically are occurring with some of the changes in energy and sleep, and they are occurring together in a cyclic pattern, as opposed to reactionary to something in the environment. So that, again, kind of going back to that behavior, when someone's reporting a behavior, I want to really know, is that happening out of the blue? Because if someone just starts not sleeping well and responding, and there's, that's very different than feeling really angry or feeling really violated by someone or taking a hit on a drug and having a response. And so you want to look for that sustained sort of out of the blue. Not to say that there can't be triggers for mania, but it's not going to sustain itself beyond the trigger. If it, mania will do that. And again, you want to understand what that means. Having florid mania is really going to impact most people's activities of daily living. It's going to make working hard, it's going to make school hard. And so finding out if they're, people that describe clear episodes of mania, but then have no functional consequences, that there's something else kind of going on. And then certainly substance use. Substance use is something worth screening everyone for. And lots of people don't consider some things substances. And so I really try to ask very specifically about tobacco, marijuana, and alcohol. People do not identify those or anything that has maybe a legal attribution as maybe something that's a drug. And you want to ask neutrally and clearly. I tend to kind of always say, I want to give people the space and rapport to say yes. So if I want to ask the question in a way that allows yes to be an okay answer. So I tend to sort of ask, tell me how much tobacco you use. Tell me how much marijuana you use. Tell me how much cocaine you use. Because it allows them to say yes, and I don't set it up for an expected no. And if they don't use, they certainly say they don't. But it allows for a positive answer. If someone is using and they need detox, especially for things like opiates, alcohol, benzodiazepines, we actually do need to know the full amount and how often they're using. Some substances are lethal in withdrawal. Alcohol and benzodiazepines, people can die from when they stop using. Opiates, you can't usually die from stop using, but you feel really bad. And we want to try to make it more comfortable so they don't reuse, and the amount matters. So we probably get into amounts a lot sometimes for purposes of knowing how to dose our medicines. And then the other big area that we screen for is these cognitive complaints and memory complaints. And this can be a wide variety of things. One of the more common things would be things like people truly presenting with memory problems that might represent Alzheimer's or a neurocognitive disorder or some type of dementia. And with these patients, people that truly have memory problems aren't going to present saying they have memory problems. That's sort of by nature of the memory problem, that they're not going to remember because they can't remember. And so with older individuals, that information from caregivers is really, really critical. And you may need to have some scoreable instrument. We have this 30-point scale that asks questions on basic memory and drawing and manipulating some information. And it's pretty easy to administer. And getting a number from that can be really helpful to see if there's some cognitive things. There are a lot of people that complain of cognitive complaints. I'm having trouble remembering. I'm having trouble paying attention and focusing. Those certainly warrant additional information, but often is coming from other diagnoses than a true memory problem. The other thing that is important is ADHD with kids is sort of a cognitive complaint. And trying to, when someone says the kid isn't listening or they aren't learning, you're trying to understand at what point and what reason are they having trouble with that part. Are they having trouble hearing you in the first place and coding it because they can't pay attention? Are they having trouble manipulating the information once it's in there? Are they having trouble taking it out? Is there a speech problem or a communication problem that makes it hard to communicate back what they learn? And so you're going through the different stages of that to try to fully understand where they're having trouble. When a patient truly has a memory problem, especially an adult with dementia, you're really looking again at those functional capacity issues. Are they misplacing things? Are they paying their bills? Are they not using words or losing language? Are they getting lost and wandering off? With ADHD, I want to understand are they struggling at school? Are their grades dropping because of it? Are they so impulsive that they're they're dangerous? Are they running out in traffic? How significant is that symptom? And then with all of these things, stresses and their psychosocial world are going to play huge components. And I really do want to spend time understanding that. And these are things that often I understand over time, especially the interpersonal conflicts, because those aren't things I'm going to fix very quickly with medications, and those become really important keys to identify in reaching out to services or treatments for therapy. But if the real conflict is coming from an interpersonal challenge or parent-child relationship problem or communication problem, that's a really different process to kind of work through than just treating depression. If a patient's having trouble paying for their medications or doesn't have a place to live or steady food, we have to address those basic needs before we're going to address the more specific medical needs. So we try to screen for all of that as well. And this is a little bit beyond the full discussion here, but I also really want to make sure I ask my patients if they've had suicidal or homicidal thoughts at any point, especially when talking about mood disorders. But actually in kids and even some adults, untreated ADHD, impulse control disorders actually have higher rates of suicidality than even mood disorders. And so it's really important that I know the safety status of people. And I make sure I set a willingness up to understand that I'm a safe person to help with those thoughts. Because again, lots of people have this sense that they shouldn't have those thoughts, and it may be very hard for them to tell you, and it's really important for them to tell you. So trying to set up the conversation so that they can say yes and know that this is a safe place to say yes to that is very important. I'm going to pause there because a lot of what I'm going to go into next is asking specific questions about past history. Does anybody have any questions about sort of understanding that presenting complaint?
I didn't have a question, but I did, I found it really interesting what you said about like sleep and mania, because I didn't realize those nuances. Mm-hmm. So thank you for sharing that.
Yeah, thanks. Okay. And then there's a lot of sort of past information I just want. Lots of times I'm not the first person they've sought help from, you know, and I think that's one of the things I always try to be respectful of, is that, you know, it's hard for people to seek treatment for mental health, and it's sometimes hard for them to get a diagnosis or accept treatment. I don't know if this statistic is true or someone just told me it once, but one of my supervisors says, you know, people kind of need to hear things sometimes 2 or 3 times before they buy into something. And that's certainly been true as I've worked longer. I've certainly had people I'd made recommendations to at that first visit, and then they disappeared and I didn't see them again. And they popped up again and said, yeah, I think we're ready now. And we weren't really ready to hear it. Or sometimes they're upset when they hear it. You know, especially I think sometimes with my kids with ADHD, it's really hard to think that might be what's going on. And so, you know, people really need some time to process things. But I also may have been the third person they saw. So I want to understand what their treatment history has been. So I do ask people what their past history has been. Have they seen a psychiatrist before? Have they seen a therapist before? Because I'm a kid person, if they saw a psychiatrist, I want to know if they saw a general psychiatrist or someone that may have had more specialty with kids. I want to understand if their work has been limited to outpatient. Most people that seek mental health treatment, about 85%, will never have an inpatient admission. Most of our work is outpatient. And so when someone has been admitted before, that sort of is a different kind of patient. So I want to understand why they were admitted, what the significance of that was, and the reason, and how often they've needed admitted. When I get really specific about my medicine stuff, I actually want to know what medicines they tried, what dose they got to, how long they stayed on the medication, and in a lot of details sometimes, because a lot of my medicines that we've talked about before take a long time to work or have to get to the right dose to work. And so it's real easy if I just bump up a dose because it was underdosed. But sometimes it's really that simple. Sometimes it's not. Sometimes they had a significant or severe side effect to that medication that may have been because it was the wrong diagnosis, or there's some metabolic issue in how they process medication. So I get really detailed about that when I'm starting to think about medicine. And again, I want to know about past suicide attempts and that substance use history and treatment. And you know, a lot of folks with substance use will also have comorbid mood or trauma symptoms, and you really have to spend a lot of time kind of teasing out the details of what came first sometimes. And I'll ask people with substance use struggles, you know, has there been a time where you haven't used as much alcohol or tobacco or marijuana, and how did you think your mood did during that period? Has it always kind of come together? Are there discrete periods where you didn't use that you felt differently? And trying to understand that as well. And then I ask all the doctor questions. I want to know people's allergies. I want to know what they're taking now. I want to know if they've had surgery and the other medical things that they have going on. Social history, again, so important. Who do you live with? You know, who is in that house? Who are your, you know, for kids, who is your parent figure? You know, who, you know, do you go to school? Do you work? If you're an adult, who do you live with? Who do you consider your support? And especially with adults, and kids too, I guess, I've really learned not to make assumptions about that. I don't assume that their spouse is supportive. I don't assume that because I think sometimes our bias is to think that if you're living with someone, oh, that must be who supports you. And that may not always be the case. So I almost ask people directly, who do you live with? And I said, who do you consider your support? And see if they line up. I want to know people's current educational status, if they're in school, or what level of education they've completed. Sometimes with mental health, sometimes I'll learn that people had to leave high school or drop out of school, and often it was because of mental health or substance use condition. And sometimes in the course of recovery, especially functionally, they may have goals to get back to education, and that can be a huge part of the road to recovery. So that's helpful. If someone dropped out of school really early or had trouble reading, that may be a huge barrier and something to know. And I'll even ask adults, you know, how did you feel you did in school? You know, did you have, and some people will say I had trouble socially. So did you ever have trouble academically with the reading and writing part either? And sort of try to separate that out. With kids, I'm always asking about development. You know, did you meet all those milestones, walking, talking, and stuff on time? Always ask about trauma and abuse. Also ask about legal involvement, and just ask that again kind of neutrally. You know, have any of these problems ever led to problems with the legal system? Are you having any legal stressors right now? It's kind of a nice neutral way, again, just allowing people the opportunity to give a yes answer to kind of understand where they are. Family history is important for many of the things I do. Things run in families, and many things run a lot in families. ADHD is incredibly common genetically. Mood disorders have significant genetic overlays, as do substance use. And I usually ask people, after I really understand their initial complaint, my usually first question is, has anybody else in your family that you're aware of, your blood family, ever struggled with any of the same problems that you do? And it gives a nice, I think, reflection about how people see the members of their family too, but that's a good way to ask. I might ask directly if they know if anyone in their family has had any struggles with mental health or addiction. But I also want to know what helped or didn't help the family member. So if the patient says, yeah, everybody in my family has this problem, I ask them, well, what have they tried? Do you know much about what help they've sought? And sometimes it's actually a real opportunity to validate that they got help, because sometimes people will say, nope, they would never go get help. And they say, but I want to help. I want to be different. And that, I think, is really helpful information too. And then suicide attempts actually can run in the family, and having a family member commit suicide and be the child or a relative of something is really actually a different risk factor for suicide, can actually elevate people's risk for suicide, because there are some, again, genetic links about suicidality, but sometimes people have very different responses. And It can be anger, almost like, well, yeah, my dad committed suicide when I was a kid, and you know, it was his easy way out, and their view of suicide may be very different than someone that isn't familiar with that. So that's always helpful to ask somebody. And then this is something, again, that sort of is the whole experience of how do I describe what I see. But during, of course, this entire discussion, I'm really paying attention to what's in the room. Not only am I listening to what they're saying, I'm listening to what they're not saying. I'm trying to really pay attention to what I'm seeing. How are they interacting with the person they brought with them? Am I seeing signs of depression or problems with mood in my office? Am I seeing issues with attention and focus right here in this conversation? Are they thinking clearly? And this is our physical exam in psychiatry. That's called a mental status exam. And we're paying attention to all of these components in our interaction. And again, oftentimes what we see matches exactly what we're seeing in the story, and we're teasing that together, explaining those symptoms in that detective way. Sometimes the patient's mental status exam doesn't look at all like their complaints. You know, I have a kid who's in my office for 90 full minutes, and they're not on medicine, and they're play at the same thing for an hour and a half perfectly with great attention and impulse control, and I don't see any ADHD. That's noteworthy. It's also very noteworthy if in 5 seconds the kid runs up and down the hallway and destroys my entire office. Does it match the symptoms that I'm seeing? And then again, if it's indicated, sometimes lab work may be necessary at that first visit. And then I'm not going to go into this, but I just some things that I think I've probably highlighted. I just think it's really important in how I ask the question to be just very person-centered, very much understanding the meaning of the symptom and the intent for the patient, really understanding what I'm seeing, and still being empathetic and offering hope. But again, I think sometimes saying I'm really glad or is really not helpful. I'm really glad you came in today, and try to really avoid those things, because it's not about you. You want to make it about the patient, and really validate. This must be very frustrating. I'm sorry that you went through this, are also very incredibly helpful and hope instilling in people. But if you go too far, or you're overly ingratiating about it, it can really turn people off. And so you have to learn what someone's comfortable with and read that throughout with that. And so again, I really try to match my interview style with the patient in front of me. You know, if I can get them to talk, I really try to stay open-ended with my questioning. If they're having a really hard time answering questions, I may be a little bit more close-ended, really trying to sort of match my affect. You don't want to get, if you come in all cheerleadery with a really depressed patient, can really turn somebody off. So you have to find that balance. Likewise, if you aren't trying to be calm and quiet with a manic patient, you'll rev them right up. So you have to kind of balance what's there. And also, I really try, especially in the first 10 to 15 minutes, to not look or write anything down. One of people's biggest pet peeves is, you know, doctors don't listen anymore. They sit there and type their notes, and it's true. We have horrible documentation goals. I find it much easier to, I do write things down, but I always try to be completely without writing much the first 5 or 10 minutes if I can, to try to write as much. And I do not type while I talk. Some people have that ability, but if you do that, do not ever look at your screen, or especially in those first 10 minutes. It's a real turn off. And it's always okay to address the affect in the room. So sometimes if you see someone upset or angry or they're crying, you have to address it right then, because you're not going to get anywhere with your questions until you do. It's like the person you left waiting in the waiting room, or you were 10 minutes late. They're just pissed off at you, and it's not, you have to sit there and apologize. And just by asking and acknowledging it kind of diffuses the situation. And like on consults, when we go into the hospital, they may not even want me there. So, you know, I'll go into the room, you know, oh, your doctor asked me, I'm the psychiatrist, to come by, and oh, you did you know I was coming? No, what did they do? oh, I'm so sorry. If you don't want to talk to me, we don't have to talk right now. Oh, no, I'm just mad they didn't tell me. Sit down. And then they're okay. You always have to kind of meet them where they are. All right. Well, that is all I have. What questions do you guys have?
Thank you so much, Dr. Swagger. As always, it's so interesting and such great useful information for all of us. So really appreciate it. Any questions for Dr. Swagger or comments? Feel free to chat in as well.
I think one of the things that I noticed on one of the screens, and you maybe touched on, was like asking about legal problems. Because I think a lot of the people we worked with, maybe they have had those kind of issues. How do you gently approach that? Because it can be really stressful for somebody, I think, to answer that kind of stuff.
Yeah, and as I said, it's not something I lead with right away. And I always, sometimes it's kind of like asking about the best friend before you ask about the patient. Sometimes too is, sometimes I'll say things, is anyone in your family or anyone kind of struggling with any legal issues? Legal issues can mean a lot of different things. Sometimes people think it's like personal legal issues, and like work with kids, a lot of times the legal issues are things about custody or divorce or sort of those kind of things. So I kind of then lead with, are you having any kind of like legal stressors with custody or guardianship or any it's just like asking about are you guys having any financial stressors that I need to know about? One of the things that actually has really helped with that too is how you might organize your intake paperwork. Like our intake packet actually has all those questions kind of listed, and it's just listed as, are you having any of these problems? And so it lets people just kind of check them off, and instead of having to elaborate. And so I'll also sort of note back to that when I have it. Oh, it sounds like you guys have had a lot of stressors. Can you tell me a little bit more about this? And I'll actually show them like where they checked the box and see what they were thinking. So,
Good suggestion. I like that.
I usually with kids to throw in legal or custody stuff that I need to be aware of, and just kind of to encompass the term more broadly. With adults, I may ask, have you had any pending, or are you having any stressful legal charges or anything that you're worried about? And people often tell you things. Again, I tend to put those more sensitive things, if they don't broach it in the first part with the chief complaint, I tend to put it a little bit later. I don't know, I find if you do that first part really well about their chief complaint, even if their chief complaint's not really their chief complaint, their chief complaint may actually be the stuff you ask later. But if you've really been really engaged and really interested and really curious about what they bring, I find people are pretty open by the time I get to those harder questions with me, far more than if I led with them. So I don't know, Amanda's nodding her head. Is that pretty pretty accurate?
Yeah, I would have to agree. I think gaining their trust and addressing some of that chief complaint can be really helpful when addressing some of those sensitive topics. And, I always lead into it by telling them, like, I have some tough questions I'm going to have to ask. And I know sometimes these can be tough, and especially working with kids, like, let me know if you're comfortable talking with the kids. If not, we can figure out a way where we can still have these discussions, because we still have to ask about abuse and domestic violence and any CPS involvement. And so you can kind of lump those. That's where I ask the legal questions and drug and alcohol involvement. And so, but it can get really tense in those situations. And, just adding another thing that I always ask with the presenting problem is, what are they hoping to get from today's session? Because many of the times I have families that come with a specific goal, and if I miss that completely or go in the opposite direction, then they get very frustrated with me. So for example, if a family is coming for a specific diagnosis or to rule out a previous diagnosis, I'm aware of that ahead of time. If I have a family, I see a lot of young ones. So I sometimes see 2 or 3-year-olds that do not need medication, but they're really there because they want to receive medication. I can tailor my intake a little more to their needs then too. And especially if I'm going towards a diagnosis that they don't want, or they have some ambivalence about, I can help kind of ease that as well.
Thank you for adding that as well, Amanda. Dr. Swagger, I know you had mentioned on that slide about the cognitive deficits, and with older age and dementia can come with depression a lot of the times. How would you recommend maybe like the family members or that support system you mentioned, how would you engage those family members and support systems to help the individual suffering from depression and dementia?
Yeah, and again, I think sometimes that's too, figuring out everybody's kind of role in that family. Especially with dementia, that's often a situation where the identified patient really may not be able to do those things for themselves. And so the information and it's kind of with kids too, you have to provide what the parent can do or not do, but you also have to understand how the patient might view that other person's interventions. And so with dementia, if there's components of paranoia or other parts, that family members' interventions might be viewed really differently. So it's just a lot of psychoeducation. One of the things, especially with caregiving and a lot of the data, and for all the folks on PBS, this is really important, is you have to a lot of the best success is really helping, this is the idea of mentalization. The idea of, can the caregiver truly understand what the experience that the patient is going through? So whether that's dementia or ADHD, providing this idea that maybe I could understand why that person's paranoid or why they're frustrated, or if I can truly understand why the child's having problems paying attention and listening, if you can get to that point of helping the caregiver really understand the extent of the problem, you will have far more success with any of those interventions. And so that initial work with caregivers, whatever the age may be, is really that psychoeducation of what is going on with this process of leading to these symptoms, and helping them understand it so that the interventions that they deliver can effectively be done. And sometimes also deciding what the patient can do and what the patient cannot do. So with dementia, it's making kind of hard decisions about, can they drive, or how do you get them to help them pay the bills in a way that they can accept, versus when do you need to make the call that I'm taking this from you and you need to do that, and just walking them through the different steps with those things. But it also helps to know what the priority of the patient is. If a patient still has some ability to tell you what their wishes are, like, I want to stay home as long as I can versus go into a facility, you can kind of negotiate some of those family dynamics. So if the goal is to stay in my own home as long as I can, well, to do that, we might need your son's help paying the bills. Is that, and kind of those mutual kind of goals that you kind of negotiate. And so really it's kind of like this dance of what it is. But that initial psychoeducation is just so important, because if you don't have that, if they don't, all the interventional stuff that you try to lend, they're not going to understand why they need to change it. And sometimes in those caregiving situations, you're actually asking the caregiver to change their behavior. With kids, it may be how to teach them differently, or how to get them to do tasks differently than they're used to. With dementia, it's sometimes like you're essentially asking a child to now become like the adult figure for this parent that they were, that was their parent. And so you're really trying to balance that. But as I said, you really, that just understanding, and I find it really helpful to just lay it out, like your loved one has a memory condition. They can't handle 5 new things. We need to think about making their environment as helpful as we can. We're going to label everything. We're going to color code things. We're going to make sure they have this place and it's consistent as possible. We're going to make a visual schedule, or we're going to make sure the lights are on. And again, breaking it down into like the simplest, smallest components can really help.
That's very helpful. Thank you. Any other comments, questions? Maybe personal experiences you can share with the group. Feel free to unmute. Alrighty, well, thank you all so much. This has been a great session, and thank you so much, Dr. Swager, for preparing that didactic for us today and starting us off so strong for the new year. As always, we encourage you all to submit cases or just questions through the online case submission form, and I'm always there to help you along the way if you need help with submitting a case or anything. So don't ever hesitate to reach out with any questions. I wanted to thank Stacy and Jen again for taking the time to explain the PCORI depression study to the group, and we really appreciate your time as well. So just a quick announcement is that our next session will be on January 20th, and that'll be from 12:30 to 1:30, and Dr. Lillard will be providing our didactics, so keep an eye out for that reminder, and Happy New Year. We'll see you guys all next time. Thank you.